Healthcare in the Georgia Emerging and the Georgia Emerging Infections Program. So half of it will deep dive into some of our perspectives about how to develop fire solutions, and then you'll get an actual use case example as well. As we go through this, Adele, Amy, and I are used to interjecting and interrupting each other if we have things to add. We are not taking offense to each other, so just know that we're used to kind of popping in and adding in additional perspectives. As we worked to develop this particular presentation, we actually were thinking about it from different perspectives, not necessarily knowing all of your roles and all of you who are joining here today. So certainly you might be an app developer, maybe you're in healthcare looking to build your fire capacity. Maybe you work in public health wanting to do the same thing, or at least over here in the United States, we work a lot with regulators, so you might be a regulator looking to support the growth of fire and be thinking about policy. So we didn't give you individual slides for each of these perspectives, but we thought about this as we developed each of the subsequent slides. We'll fly through the next few because then I want to make sure that we linger in a few slides down the road and spend a good bit of time. But first, just want to go into what we look for in a fire partner. At Emory Healthcare, we started our fire journey back in about 2017. And I would say at the time, for us, it was so nascent and at kind of the forefront for adoption in the US that we had specific processes for evaluating fire solutions and fire technology developers. And now, because it's been around for so long and is so widely adopted within the United States, a lot of it is just folded into what you would do for any tech development, whether it's fire or HL7V2 or just something completely different. And so some of the things that we've learned through lessons learned over the years of what we want to look for in a partner or just a technology partner in general are those that are ready for organizational technology acceptance. And so what that means is have you thought on the healthcare side, or if it's you're working with public health partners, what they need to be able to accept technology into their organizations. So for example, sometimes that's the debate around open source or not open source development. And so for us, there's some friction there a little bit when it comes to clinical and public health settings in the US, because a lot of times we want to develop in public health open source tools that can be, shared openly within everyone. When it comes to security review for those on the healthcare side, that then can be challenging. So there's, an intersection there of needing to understand what type of organization you're working with. And in that vein, we look for folks and organizations who are prepared and understand and adhere to all of the basics of security compliance that you would for any technology solution that you are vetting. Has it been reviewed by, a third party security review organization? For us, those are things like SOC 2 reports. Do you have the right access controls in place? Do you have the right audit logs and monitoring of activity for your solution? And then we also look for folks who are prepared to come for legal negotiations with their red line when we're looking at contracts and license agreements. So some of the things to think about that if you are coming and looking to partner with us, those organizations that adhere to our insurance requirements that we have, that are ready to adhere to security requirements, that will work hand in hand with us in developing a business case, that have thought through the full scope of their solution and all of the details regarding data that will be used and disclosed, different departments and operational areas that will be affected, budgetary implications, not just at original onset of the project, but for long-term maintenance. Come to us with a project plan so we don't have to build it out ourselves, operational and change management plan and communications plan as well. So again, whether it's fire or anything, really looking for those that are prepared to partner with some of these more along the maturity model of tech organizations, those that are at the farther end of the scale. Amy or Adele, anything to add on this one?
I was just going to offer that I think those last three bullets are often the things that we find trip people up. The easiest. It is often an afterthought in many projects to think about training and implementation. But when we see folks who come ready with a project plan, ready with change management principles in hand, ready with communications artifacts, or at least considerations of the audiences that will be impacted, the end users that will end up encountering this application, that's who we know has done their homework. So
Mhm.
not ones to
Right.
neglect. Yeah, thanks, Elizabeth. I'll pop to the next slide.
Perfect. I'm going to fly through the next two, and then we'll get into some heavier details. But again, this reiterates some of the things that was on the previous slide. At least for us at Emory Healthcare, we have a governance process that I'm sure if you work in a healthcare organization or public health or really any organization, you probably have a governance process as well. That just starts with an intake of submitting a new project, needing to be prioritized by the proper committees, legal and compliance review. Often it goes through the operational or clinical teams for review. It's got to be fitting into the budget. The security and technical review, data governance, and really what does that ongoing support model look like as well, which is absolutely key. Right. Next slide. For us, when we're thinking about some of the facilitators and barriers just to electronic health record and data, often Adele and I in particular sit at the intersection of clinical and public health, where public health is looking for electronic health record data, and us on the clinical side also is seeking data from our public health partners, be that immunization data or closed loop social services referrals. And we are always keeping in mind some of those facilitators and barriers to electronic health record data. So, from a facilitator perspective, as you can imagine, using FHIR, especially, you can get access to the whole longitudinal record of a patient's chart and not just set to a single specific encounter. There's a large volume of discrete data, but if you have been working in FHIR for a little bit, you also know that there's the power of unstructured notes and using that docref resource, FHIR resource, in order to be able to harness the power of unstructured notes and perhaps run AI on top of those in order to expand on what you have for the discrete data. Here in the US, we have a real national movement to standards. I think that you do as well when we've been meeting with some of the folks from your national science agency. And that's been huge because that means you can get your LOINC codes for your lab orders. You can get your SNOMED codes and your on our side ICD-10s for diagnosis codes. And we have a real growth and interoperability here that makes FHIR kind of just now par for the course, which really reduces the barrier to implementation. But we also have barriers, as I'm sure you can imagine. Not everyone seeks care from healthcare, so the EHR is not the end. At least here in the US, when it comes to management of your problem list within your EHR, so your conditions, that management is very variable and can be something that is hard to count on. So I often find, and I think Adele does as well, that folks are looking toward the problem list, trying to have it be an absolute source of truth to a patient's past and current diagnoses. And the management of those is not always consistent across healthcare. And those data standards journey, as you all know, is it is a long haul. And so, how often you might be met with a beautiful FHIR JSON file that has unique local codes that are extensible within the FHIR implementation guide. We are also navigating privacy preserving measures so that are there for a reason, but you have to keep in mind when considering what data you can get access to. So we have at Emory Healthcare, we're live on Epic as our electronic health record vendor. And we have things such as Break the Glass, which can help facilitate locking down certain data elements that we wouldn't want to share with external apps. And then you just have documentation variability. So you may be popping into those unstructured notes in order to harness what they have in there. And it may vary what you are going to end up getting. And you may be looking for something that's not ever documented in the notes. Anything to add, Adele or Amy, to this one?
I think I've learned so much about variability in standards adoption and documentation from you, Amy, and from your fellow surveillance epidemiologists who work on the emerging infections program, who can tell us like how incredibly varied the data that you all receive through things like electronic lab reporting, just even within a state. I don't know if you want to speak to that a little bit, but I think that that has really opened my eyes to those barriers across organizations.
Yeah, I'll just add in public health, it's a moving target. So as variable as it is, it even once we understand it, it's constantly changing. So that's also something that
Mm.
comes up with a lot of this work is that, even once we've locked things down, there are changes and updates and things that we have to take into account and be prepared to handle as well. So
Mm.
It's a great point. Great. All right, next slide. So, specific to a fire project, these are the teams that we now have learned over and over again that we need to have on projects, especially in the healthcare space. So, we involve our informatics team. So, these are often folks who are or were practicing clinicians, either nurses or physicians, who now are really working in the technology space as well and can speak to the clinical workflow and understand how the solution that you're looking to engage with works within the workflow. Of course, a project manager, clinical subject matter experts, but specific to fire projects, you're going to need an interoperability or an integration team, data engineers. You're going to need analysts to support your cohort creation. That's specific to if you all are using bulk fire. So, you've got your single patient fire, and then bulk fire is looking across populations. And to do that, you have to create cohorts, and that usually takes a tech analyst on an IT team. And then terminologists and vocabularists. So whether you work in fire or if you work in research today, one of the kind of the least fancy but the most tedious and yet the key aspect of any particular fire project is curating your value sets and your codes that you want to be pulling from lab and SNOMED, and your ICD-10 codes. And Amy and Adele will speak a little bit about that when they are going over the Georgia EIP project with you. But that is that tedious, it's like data cleaning on a research project. It is the thing that also evolves and changes. So it's not a one and done. And it's something that takes a lot of time and a lot of validation. All right, next slide. Thank you. Okay, I have two more slides in this section. This is the one I'll spend a few minutes on, and then I'm going to hand it over to Adele and Amy to go over their case study. But these are some specific things for you to know about when you're working on fire projects in general. And I think it's a little more geared toward probably electronic health records if you're working in that space. So, some things for you to think about. One, are you using a vendor's electronic health record fire implementation, or are you developing your own? So, here at Emory Healthcare, we use Epic's fire implementation. So, with that, you need to understand how that pricing model works, and you need to understand what it is that they have or have not implemented from the fire implementation guide. So, really important to understand your fire API's pricing model and how that works so that you can be thinking about that from a costing perspective. You will probably have different pricing for if you are an app developer, what it costs for you to engage with an EHR versus if you are the healthcare organization. In addition, if you have built your own fire implementation, it's then you get to determine which parameters within the fire implementation guide that you implement. You also need to plan for your program management. So, thinking about things around being strategic about the timing of your fire queries. So, if you are connecting to an electronic health record, or if you're a healthcare organization that's allowing an app to connect or developing a solution with them, when do you want those fire queries to take place? Is your fire server or fire facade built on top of your production database? You might want to be able to time those in the evening. Or have them set to happen, once a week, depending on what your particular use case is or what your volumes are. And then plan to track your fire traffic as well. So we monitor and have the ability to see which apps are hitting which APIs and just, keeping an eye on that too. but truly needing to understand your fire implementation. So, for example, what access controls can be put in place to align with providing minimum necessary data to any particular use case and being a good data steward. So, for example, on our end with Epic, for all of our fire apps, whether it's a smart on fire app or if we're using bulk fire, there is the creation of a background user. So it is a fake user within the electronic medical record that is given security provisions the same way an actual user would have security provisions. So they can access what they should be accessing. And that's one way to keep your data secure. So needing to understand what that might be and what that process looks like for your organization. Also, for your organization, are there additional opportunities to map to standards? So do you have unmatched data? Does your EHR, have they taken the term extensible to to heart and allowed, and and not mapped to standards for things like encounters or even labs? Is it extensible? And those are things that you will need to know, because perhaps with each healthcare organization you work with, if you're a fire app developer, it's going to be different, and needing to understand uh, how much the healthcare organization can map versus how much you're just going to have to learn to work with. Then, thinking through what are the nuances of the fire implementation. So for all of you, as you're exploring fire implementation guides and what a fire implementation should be able to support, know that that can be variable, at least based on, especially here in the US, whether you're on Cerner or you're on Epic or whichever EHR you are on, the implementation may be different, and you might need to know what those variabilities are and what parameters are supported or not. So for example, we underscore sense, being able to look at data from a particular period of time for us is not supported currently within Epic. Underscore type filter and wanting to pull, specific, maybe just encounters is supported. And so that's a way to make your fire exports smaller and more manageable. Do you respect break the glass or other sensitive data configurations? So for us, again, um, what's really great about the Epic Fire implementation is it does respect break the glass, and so we can set up whether an app has that ability to break the glass to get to sensitive data that a provider typically has to take an additional step in order to access, and so that gives us some level of control, or a good level of control over the data that can be provided. Does an organization have restrictions on how frequently or when a client can query the Fire server? And if so, how does that affect what your strategy is around that? Can a client query more than one group at a time? So this is relevant to bulk fire. So Epic supports bulk fire and pulling data across a population. In order to do that, you have to create a cohort or a group that then your fire query can call upon. And to do that for Epic, it is through the creation of a patient registry. And I believe that the client can only query one patient group at a time, or at least can only query that particular group at a single time. So if I wanted to do separate queries for, say, the patient resource and document reference, because document reference might be very large, I need to plan that in a strategic way. And then are there restrictions on the number of records in an export? So if you are starting to kick the tires on things like bulk fire, how does it handle whether you want to pull 1,000 patient records or if you want to try to pull 10,000 patient records? And if you want to pull 10,000, what's the difference if you want to pull everything on a group of patients, or should you try to break that out into pulling observations at one point and then doc ref the next point, depending on what the performance is of your bulk fire export? So lots that you can start to really get into when you're developing your strategy and navigating it, and that it just takes doing it, and having an opportunity to explore and continue to learn all of the different nuances. But you can come up on a lot of little hiccups along the way that then you can have in your lessons learned bucket for your next project. And then Adele and Amy will talk about this as well when they talk about the use case, but determining how you'll navigate testing and creating test patients, which can be, which can be tricky because test patients are only ever test patients, and sometimes you need to get into production to really see how things go. All right. Next slide, I'll knock this out and then I'm going to hand it over to Adele and Amy. And Adele, you can also add anything you want in before you guys go into the particular use case. This is just the last consideration slide for you as you're working to develop fire solutions, whether in public health or in clinical spaces or wherever you're working, is to really consider your workflows. And so this is relevant whether it's a fire app or anything else, but thinking about how does it really embed in the workflow? Who can access it? Are there requirements that are specific to an organization? So often, and not so much now, but I would say in the beginning, back in 2017, when fire folks would come to us with a tech solution, there were things that we had to do that they had not thought about around saving data to the chart, not having a shadow record that lives outside of the electronic medical record, thinking about what we might have from a requirements perspective to put the source attribution of a decision. So if you're using like CDS hooks, but wanting to prompt a decision support for a provider, but making sure that perhaps that source of that particular input is documented in some way, what note signing requirements you might have. We were working several years ago with an app that we wanted to write back a note to the chart, but we realized we weren't going to be able to support a co-signature requirement and had to really back up and figure out how we were going to integrate that within the workflow. And then while we always want to use FHIR to add into the alerts, I'm sure if you any of the clinicians on the line know that there's a lot of alert fatigue out there. So prompting and putting things in the workflow, making sure you're being deliberate around when that is absolutely necessary and when it's just creating noise. Okay. With that, I'm going to hand it over to you, Adele and Amy. Anything you want to add on this part? But I know we have some fun things to show you all about our particular use case and project we've been working on.
Thank you so much, Elizabeth. One last thing I'll add here that I think we learned through a series of complex apps that came our way is just how much all of these considerations increase. Sometimes it feels like tenfold when there's multiple users of an application. So if you have an application or a solution that both faces patients and also clinicians and also care managers, how some of these considerations just kind of balloon from there. So there's nothing wrong with a minimum viable product to get something started and go from there. But with that, I will hand it mostly over to Amy to kick us off on a little bit of background on the Georgia Emerging Infections Program and our data flow project. So I'm going to jump right into the next slide, Amy, and hand it over to you.
Sounds good. So the impetus for this project was born really due to the very manual current processes of data collection for our public health surveillance. And with the increasing acceptance and use of healthcare standards, we are certain that that a lot of the data that we need could be collected much more easily and more efficiently through modernized data exchange processes. This could improve the speed and accuracy of surveillance data, provide opportunity to collect more cases or more case-related data, and really inform public health trends, interventions, policies related to these diseases in a much more efficient manner. So we began this pilot to really enhance the workflows of our surveillance epidemiologists and the exchange of public health data with our clinical partners at Emory. A bit more about Georgia EIP. I won't go into too much detail, but just want to give you some perspective on our state and how surveillance is divided. So we have two main geographic areas that are vastly different in physical size. So you can see all of those light blue counties, which are lovingly called Georgia outside of Atlanta or GOA. And that surveillance is done by the Georgia Department of Public Health and has a population of nearly 5 million. And then the portion in red and the darker blue is what we consider the 20 county metropolitan statistical area of Atlanta. And that is the particular surveillance group that I work with. And we have a population of about 6 million. So all in all, a little over or close to 10 to 11 million people under surveillance in our state. And then, yeah, you can go to the next one. So Georgia EAP has four main areas of disease research. So we have our foodborne pathogens, which is our FoodNet program, which has multiple bacterial and some other pathogen types. We also have our RESTnet, which is our viral respiratory pathogens. There are three of those. And then we have our healthcare acquired infections, or HAIs. And there are several project areas within that umbrella. And then we have our active bacterial core surveillance, which is highlighted or bolded here because that is the one we will focus on for this use case. But essentially, all of these project areas operate under the same burden of illness pyramid and include population-based laboratory confirmed illnesses to be able to be included in our surveillance. And for this pilot, we began with one of our ABC's pathogens, which is group A strep. So I think you can probably go to the next one. So a bit more detail about our ABCs, or active bacterial core surveillance. So there are five main pathogens. So as I mentioned, group A strep, and then we also do surveillance for group B strep, Haemophilus influenza, Neisseria meningitidis, and then Streptococcus pneumoniae as well. And then additionally, obviously, Georgia is just one of the 12 CDC sites that are part of the EIP program, but sites that conduct surveillance identify changes in the epidemiology. They monitor antimicrobial resistance patterns and other characteristics of both pathogen and cases over time through the collection of both isolates and demographic and clinical patient data. For this pilot, we chose group A strep as it has sort of the broadest case definition of the ABC's pathogens. All right, I'll describe a little bit about the workflow here. So I won't go into too much detail because I know we're getting close on time, but a positive lab test is really the start of our surveillance. And those lab tests can be received a number of ways. They can be reported to public health through our state electronic notifiable disease surveillance system, or SENS, or reports can come directly to us from our clinical partners or reference laboratory partners. From there, the surveillance epidemiologists then perform case ascertainment processes by searching through healthcare records to look for criteria that are for the cases that help meet the surveillance case definition. And you can go to the next one. For this project, we're working with just one healthcare facility, as I mentioned, Emory, to use FHIR to create a scalable solution to help streamline our surveillance epidemiologist workflow. And for this use, or for this project, we have two sort of key phases, which include the generation of the line lists and the electronic health record data extraction. And then additionally, we are also hoping to populate the variables and values of the standardized case report form that is collected for our Georgia Department of Public Health and eventually our sponsor, CDC. All right. And then this last slide that I'll talk about hopefully helps visually simplify what we're currently doing and then how that will change with our modernized workflow. So on the left, you can imagine all of the different facility EHRs that supply the healthcare data that we need for this for our surveillance. And then for this project, we're beginning with our clinical partners at Emory. So in the gray box there, you can see that. But outside of the gray box, you can also see our notes about how the process of collecting data is different for each healthcare facility and requires really individualized and specialized training and experience to understand all of the nuances and differences of each healthcare system. However, in the gray box, you can see where we have inserted our solution, which will help serve as a sort of simplified interface where we will generate line lists in a standardized view, regardless of the healthcare system, even though we're just starting with one, but as well as the ability to view and review relevant clinical notes and information surrounding the cases to help with case ascertainment. And then additionally, instead of manually doing the record abstraction or transfer of the data to our case report forms, we're hoping to automate as much of this as we can, if not all of it, into our surveillance database before eventually disseminating to our sponsor at CDC, public health sponsor. So, all right, hopefully I got through that quick enough because Adele has really the fun stuff where she's gonna.
No, you did so great, Amy. And I think as we all do, there's a a necessary simplification here of the incredible work that Amy and her public health colleagues do to learn the nuances of so many different EHRs, let alone the EHR implementations across these different sites. And we really started referring to them throughout this project as disease detectives because they had to figure out how to go and find all of this necessary data in the nooks and crannies of these EHRs in their effort to complete the case report form and send it into SENS. And so I think that deep appreciation for their work was quickly gleaned by Elizabeth and me and the other kind of non-public health epidemiologist members of our team, and certainly grounded us as we started to compile our guiding principles for this project and then discover the data that would be most of interest as we crafted the FHIR solution with our development partner Remedy. So a couple of our guiding principles that we held really dear were a vision of scale. So that was something that we knew is so vital for public health that is often working with limited resources but ever increasing demands. And so we wanted to be able to rapidly scale to more use cases. As Amy mentioned, we started off with within the active bacterial core, group A strep. But we almost, I guess, within 6-ish months of starting, development, we added a use case. So we're now looking at influenza within the RESTnet team's purview, and that kicked off in September of this year. So we're really excited to start learning the differences between the different pathogens and how that work might change. We also wanted to be able to scale to other emerging infections program sites, knowing that the diseases that they surveil are different and the ways that they do them are different. And so wanting to account for those differences in our flexibility of design. Obviously, looking for other health systems, both within the metropolitan statistical area of Atlanta and outside of Atlanta, to other future exchanges via national networks. If y'all have followed anything stateside, we've been off the ground with our trusted exchange framework and common agreement, kind of our national network of networks for a couple of years now. We want to have a vision towards the public health exchange purpose that's always already live now, and kind of increasing adoption there. We wanted to account for flexibility in multiple data sources. So we've talked a ton about EHRs in this presentation because that's our bread and butter in healthcare, but there's also labs. We've got surveillance systems. There's a host of data sources that we could account for with FHIR. FHIR is so nimble. We also wanted to account for that variance between EHR vendors, so knowing where things might be mapped, where things might not be mapped, and that will be a recurring theme throughout our entire presentation. We also wanted to perform an alternative analysis, so looking at what public health already has in place and ensuring that we weren't reinventing the wheel, that this was, if we were going to build something new, that it was going to have a very clear return on investment. We also wanted to design for healthcare technology acceptance. You've heard from Elizabeth how important that is for success within the kind of healthcare settings where we've been working. So we wanted to reduce costs wherever we could while maintaining high quality of the data exchange, reducing the pull of data we don't need, considering open source, leaning on our core data for interoperability instead of AU CDI, looking at US CDI if at all possible. Integrating this into existing reporting requirements. There is a fair amount of regulatory capture here in this ecosystem, so wanting to capitalize on where folks are already familiar with having to report to public health. We also wanted to make sure that we had our paperwork ready, that we were playing nice in the sandbox and showing up to meetings with our project plans and our communications plans in hand. We wanted to ensure that we were sustainable in our design by reducing subsequent review needs. So we packed a lot of punch with our initial security review, and especially breaking up our two project aims between the development of the line list and then the actual building into the case report form. That helped us get through quickly where we could and then come back later for an additional security review once we already had some development underway, which was great. And then finally, we wanted to leverage streamlined and efficient workflows. The amount of knowledge that Amy and her team have in their mind simply cannot be translated to a system. We need something that would support what they can do, and the detective work that they perform, and automate what we could, but then just simply let them do work their magic where we needed to. Once we performed some of my favorite days at work over the last year or two, which were our on-site kind of shoulder-to-shoulder discovery days, we compiled a list of data of interest so that we would know which FHIR APIs would we be hunting for, what sort of test patient data would we need to compile, and how would we want to ensure that we were good stewards of this information when we went through our security review processes. So these are just a handful of data points, but you can kind of extrapolate it. If you're doing case surveillance on flu, you're going to be looking for labs and some respiratory support and clinical notes, things like that. Largely the same is true for Group A strep. We also wanted to understand, what does this FHIR lift look like? How much work will it require for the actual system to perform these data exchanges? And Elizabeth, Amy, please know you can jump in at any time if you have comments.
I know
Yeah.
that we're going to be needing to give a few minutes for questions as well. I'm wondering if we can show real quick the demo real
Yeah,
fast.
absolutely. Let me pause and in my slideshow, because I think the rest of ours, we're really just celebrating some of our progress. So I have the demo up and I will share my screen.
And the demo itself will take 30 seconds.
Yes.
But we wanted to show you, as Adele brings this up, these are the wireframes of what will be these are not real test patients, but the generation of a line list, and then all populated via FHIR, and then moving through and doing case ascertainments. If you can just show them, or case confirmation.
Yeah. So as you saw, I just clicked on one of our potential cases to view the lab results that would trigger these cases populating on a registry within Epic. And then our FHIR solution would be able to go in and pull that patient information with those labs, qualifying labs, into the platform that we're using. And so then I, as the surveillance epidemiologist, can go through and look and say, is this lab from a normally sterile site or not? And I make that determination. I save the comment to that lab, and then I'm able to proceed through reviewing some of the clinical notes that are also on file for that patient as I work to determine whether or not this is indeed a case. So once I've ascertained, oh, this is a case, I'm going to click Create Case Report Form, and I assign it a state ID. Once I click Create Case, in the future, our platform will then pull up all of the information that we need on that patient. So going into those nooks and crannies that we talked about from the EHR, populating it on a single dashboard where the surveillance epidemiologist can then go through and actually fill out some of the case report form fields. That's our very brief demo with very limited
Yes.
content.
And I want to give a big shout out. They're not on tonight with us, but Remedy is our development partner in this. Remedy is a FHIR app organization that has been around for several years. They're located here in Atlanta, Georgia. They're incredible partners, and they have been the ones developing this with us. I want to make sure to open it up. If anyone, I know you're probably needing to get back to your work days, but if there are questions that anyone wants us to stay on and field, we're happy to do that.
Elizabeth, before everybody leaves, this is Mark. I have actually been on the whole time, but I was in Zoom purgatory for a bit of that. For some reason, I couldn't. I just want to thank you guys. Obviously, public health is one of the ground zeros of interoperability, and I think you've done a great job of showing the HL7 folks who are embarked on this Australian journey toward a FHIR-based digital health system, the kind of thing that can be done. I'll shut up and they can ask questions.
I was going to add, thanks, that was absolutely fascinating. I mean, as we're starting our journey here in Australia, or doing this, the word variability came up a whole lot of times. The term not a one and done. And you mentioned what it is that they have and have not implemented, implemented from the implementation guide. These are things we need to know. They're important. And you know, the standard is like a baseline, and we know we're going to have to work closely with the vendors themselves to understand exactly, you know, how it's like a jigsaw. Where do we fit in? What are the parts? What are not the parts? Would it be correct to say that, you know, using something like an implementation guide, something like the standard and the version be the starting point for us?
It's absolutely the starting point, making sure you kind of making sure you're paying attention to the parameters that you may be requiring within Australia or not requiring, what is supported or not supported. Always start with that implementation guide, but hold it lightly and ask questions at every implementation site.
Terrific, thank you.
I also think, Robbie, if I might add, the way the US has driven adoption of FHIR, tying it to US CDI, I think you all have done a similar
Yeah,
or proceeded with a similar approach. And I think we've found the opportunity to engage in commenting and see what our fellow healthcare organizations or professional societies also comment on US CDI, and the adoption of standards has really helped us understand what challenges might be unique to our healthcare organization versus what might actually just be feasibility challenges generally.
thanks for that. That's very interesting. I'll open up. Anybody else with questions, please? Maybe raise your hand and I can press the allow to talk button. No, I can't see anyone. Okay, that's pretty interesting. All right, the other thing that I was going to mention then, and I think this is sort of obvious, but we really do need to hear this, that the team around the project, which you mentioned, is super critical. And I mean, when I say it's obvious, I mean you really do need the domain experts in any project, but you know, having a list of the people that, and I've seen this before in other people talking about FHIR implementation, having you know, a list, having the terminology expert, having the clinicians in the various domains. I think whereas we know this, it sort of needs to be baked into how do you go about implementing a FHIR project 101. You know, this is where you start. You can't start without these sorts of things. And I think that's really important for us to take on board as well.
Adele had one more, if you can flash your lessons learned slide, this way you guys just all have it in the recording. Because there were two that I had to skip because I had been long-winded. This I think is really hits home on some of those things in addition to teams, but perhaps is probably a good wrap up of the four key tenets that we think you should keep in mind as well.
Yeah, I Amy and I experienced a lot of creative meetings with some of our population health friends at Emory who are very fluent in Epic, who helped us understand how can we be creative when our standards might not be where we want them to be. So if we couldn't get lab results because a lab result wasn't mapped to LOINC, how could we then populate a registry for positive lab results for a specific pathogen? And so leaning into, oh, we can use a filtered list of specimen sources and then still identify a specific pathogen of interest. And so that's how we've done it for now, until we are maybe a little more advanced on our journey to fully adopting some of our vocabulary standards. Same thing with just familiarity with data standards adoption. I know the US has worked to create US CDI Plus, so specific domains that meet the needs of data exchanges beyond our core data or our floor of interoperability. There is a public health domain. And so leaning into some of those additional data models or simply just accounting for the fact that there may be other vocabulary standards that are maintained elsewhere and we can lean on those or perhaps contribute to them. the costs were a real consideration. And I think you can never start too early asking questions about what may or may not be kind of base level costs versus additional costs or whatever that looks like for the organization you're working with. And then finally, to your point, Robbie, the fact that Elizabeth knew so many people across the Emory Healthcare organization, even if it was somebody she knew from 10 years ago, it was still a breadcrumb for us to start and ask for help. Because oftentimes it's not just submitting a ticket to a queue, it's also asking questions before you're even ready for that governance process. So having somebody who's really well connected cannot be undersold, or somebody who's really well informed about clinical informatics versus physician informatics or whatever the use case may be. Knowledge is power. Anything else to add, Amy or Elizabeth?
Nope, I think that's a great summary.
There is a question that one of the attendees typed in. How pivotal do you believe government FHIR mandates have been in driving interoperability in the US context? Do you believe this is achievable without such mandates? And what do you see as the major barriers without them?
I believe that government FHIR mandates have been key in driving US interoperability, and I'm not sure we would be where we are today without that. And it's almost just because there's, in good faith, there's a lot of competing priorities out there, and so having a little bit of a regulatory push can help move us in that direction. I definitely feel that bulk FHIR required a mandate that was required as of December 2022. And so we were one of the early adopters of kicking the tires. We're working on some bulk FHIR projects now. Um, I think I, I think the mandates are pivotal, and I'm not sure we would be where we are without them. And I'm not sure what the future would be without them.
I think it's boils down, Elizabeth, completely agree with you. It boils down to if you want to go fast, go alone. If you want to go far, go together. We would not know where to focus our energies as an industry and with all of the
Mhm.
other domains that rely upon healthcare data for secondary purposes without having a referee to say, team, there's a lot of work to be done. We got to start here. And certainly I would say beneficial and or perhaps benevolent relationship that the government and the US has with standards development organizations for purposes like these, the way that standards development organizations support innovation and interoperability, I think has made it so that there's not been resistance when the mandates have come down. It's just like figuring out how we all get from A to B. So I completely agree.
Yep. And I think that standards advancement process, everyone has a seat at the table, whether you are an EHR vendor, whether you're a health information exchange, healthcare organization, public health partners. Um, I think you said it way more eloquently than I answered it, where it does feel like a group project, and we are all moving in that direction, and that regulatory push has been key, but it is not done in a vacuum without input. Great question.
Yeah, it is a great question, and I can only agree with what you just said. Um, I guess I've been in this longer than most people on this call. And my brilliant former Georgia Tech colleague, Bill Rouse, described healthcare accurately as a complex adaptive system where the players are at cross purposes with each other and have different incentives. Without some outside entity with the power to do it, saying this is the way we're going to do it, we would have never done it, in my view. And it's interesting, governments around the world are doing the same thing. It's not just Australia, it's India, um, and many other governments around the world. It's essential.
And you're right, Mark, you have been. For all of you, little anecdote, I think it was 2017 when I first met Mark, and it was like, um, hi, I don't know what I'm doing. And so, here we are. So thank you so much for being a mentor and a guide to so much of us working in this area.
Are there any more questions? Hands or type them? All right, well, I'm going to say in that case, thank you very, very much for your time this late into your evening. It's really appreciated. For me, that was absolutely fascinating. And I think we all got a lot out of that. Mark, thank you so much for organising that. It was terrific. We have a journey here, and these sorts of lessons are very valuable for us. We really have a lot to learn. So thank you very much. And look, we'd like to sort of invite you back later on. Maybe we can do something where we can tell you how we've gone in some projects, and you can help us out and point us and that sort of thing. So thanks a lot, everyone, and good evening and good afternoon. Thanks, everyone. Bye.
Thanks.
Take care.
Bye all.